Hello, my name is Dr. Jay Mathews. I'm the director of the Cardiac Cath Lab at Manatee Memorial Hospital. I have the pleasure today to share some COBRA cases during the COVID-19 pandemic. Our hospital is notable for progressive cases since March. Our ICUs remain at capacity, and we've seen a lot of increased COVID-related thrombotic events, including increased stroke, VT events, acute limb ischemia, myocarditis, and COVID-related STEMI and NSTEMI. There have also been a lot of non-COVID related halo effects, including delayed presentation MI with mechanical complications, including VSD, non-COVID related VTE with very organized thrombus, and delayed presentation acute limb ischemia with neuromotor dysfunction, ultimately leading to amputation. These are our current numbers. We have at least 30 patients in-house with COVID, another 7 patients that are PUI, and another 40 patients that are under precautions. These numbers are down overall. In Florida itself, we have over 580,000 cases right now too, and in our county, almost 10,000 cases. These numbers are dropping. I want to share my first case, which is a patient that's 65 years old with hypertension and ongoing smoking abuse. The patient also is somewhat non-compliant, and he was refusing most of his medications, including heparin, despite presenting with troponin elevation. He had really non-specific symptoms, but his troponins were increasing, so we decided to take him to the cath lab. His labs were just remarkable for anemia, which may have been related to his long-standing alcohol abuse. In addition, he did have some elevation of his pro-BNP. His platelet count was okay. The only reason we knew that he was COVID positive was because we tried to check COVID status prior to performing procedures in the cath lab, and he was found to be an asymptomatic positive case. This is the reason why we didn't have a lot of the acute phase reactants that we would normally get with COVID patients. So in this case, you can see that there's a high-grade proximal LED occlusion, and despite this really severe lesion, the patient wasn't having a ton of symptoms, and you can see on this other view how significant this is. His LV function was remarkably preserved despite this occlusion. After crossing this, we ended up performing a high-pressure balloon inflation, in addition to using a cutting balloon as well too, in order to be able to deliver any equipment. We did perform intravascular ultrasound, which suggested that there was a significant amount of calcium. The COBRA stents did cross quite easily, and we placed a 2.5 stent in the mid-segment at 14 atmospheres, and also approximately another 3.0 stent as well at 14 atmospheres. Afterwards, we post-dilated this to 3.0 and 2.5 respectively, and you can see our results were excellent with improved TIMI3 flow. Intravascular ultrasound revealed no evidence of edge dissection or distal vessel compromise, and the patient did well. And now this type of patient in general, given the fact that his D-dimer was elevated as well too, normally we would have put him on some type of DOAC as well too for at least a month. And anecdotally, we've seen some improvements in these types of patients doing that type of therapy. However, he refused anticoagulation, but was able to take the aspirin and Plavix that we prescribed post-procedure. He's somewhat lost to follow-up at this point, unfortunately, so we're not sure what his ultimate outcome was going to be, which is one of the reasons why I was pleased that we did use COBRA stents in this particular case. This is a different type of patient, obviously a lot more sick. He's a 75-year-old gentleman with known metastatic pancreatic cancer, status post chemotherapy 2 months earlier. He was admitted with chest pain, diarrhea, and fevers. In the later phase of the pandemic, a lot of our COVID patients started having more GI-type symptoms, and that was very typical. He had actually presented to the hospital 3 days early with atypical chest pain with negative cardiac enzymes. But on this presentation, he showed up with inferior ST elevations. His troponins, and this is a regular troponin I, was quite high at 40 with an elevated pro-BNP. In addition, his LDL was quite low at 14. His white count initially started okay, but then dropped significantly to 1.83. His platelets were dropping, and he was also anemic. In addition, as expected, a lot of these acute phase reactants were elevated with an elevation of the CRP, ferritin levels, procalcitonin, and ESR, and his D-dimer was also quite high. As expected, his COVID-19 did turn out to be positive. You can see here he has a proximal RCA occlusion with TIMI0 flow. We went in with a Indigo CAT-RX catheter, performed mechanical powered aspiration thrombectomy, and afterwards we were able to restore flow. And you can see that there's an ulcerated plaque with thrombus in the proximal vessel, and also a high-grade occlusion distally going across the RPLV into the RPDA. So we went ahead and used the anchor balloon technique with a guideliner and stented the proximal vessel with the 4.0 COBRA stent quite easily at 14 atmospheres. IVUS did show that the vessel was quite large and ectatic at 5.5 centimeters. Distally, we went ahead and stented with a 3.015 COBRA stent at 14 atmospheres with quite nice results. And you can see the flow is better. The RPLV's got a little bit of slow flow. But fortunately, after giving intracoronary integralin, we did have some improvements there. The proximal stent was post-dilated at 5.0. And you can see here we have TIMI3 flow with some moderate residual mid-stenosis as well, too. Ultimately, the perfusion of the RPLV looked a lot better by the end of the case, and there was a decent myocardial blush. And you can see here on the LV-gram that the LV function is actually relatively normal with only some mild hypokinesis of the basal inferior wall. This is what his left circulation looked like as well, too. We ended up doing some intervention later on to his circumflex territory as well. He's got a very ectatic distal left main. Post-op, because of the elevated D-dimer, we did also put him on Lovenox injections in addition to Plavix monotherapy. The reason why we went with the monotherapy was we were concerned about his bleeding risk. And the patient did great from a cardiac perspective, but ultimately developed progressive pancreatic cancer and eventually went on hospice several weeks later. Thank you.